Hi all, today we are going to discuss about the topic abnormal labor and deliveries. So in today's session we'll see about the abnormal type of labor or abnormal delivery. Here we'll focus on the three major points. That is, first one is we should know what is abnormal labor and understand its modern diagnostic techniques. Second is the classification, the classify the common patterns and causes using the 4P framework. Third is to learn the practical stepwise approach to investigations and management with the clear OPD and IPD basis. So that is the uh, important points we are going to discuss in the today's session. Definition of the abnormal labor. So, what is an abnormal labor? Usually, we can call this abnormal labor as called as dystocia. So, as clinically, when if we are defining, dystocia means the abnormal progress of labor with slow latent phase, protracted or arrested active phase, prolonged second stage, or complete obstruction. So, that is the causes of dystocia. So, by the modern guidelines, we can emphasize the active phase starting around 6 centimeter and define the active phase arrest when there is no cervical change despite the adequate contractions or after a defined interval with the inadequate contraction. So, this is the criteria, so use this institutional criteria, but you should also be knowing the guidance from ACOG on arrest and dystocia. So abnormal labor is the deviations from the normal progression of the labor. It can involve the issues with power or passenger or passage. So if for example, if the patient is 7 centimeter dilated and has not changed for 4 hours with the good contractions, what are our options? First thing, you have to assess the adequacy of contraction. Second, consider the oxytocin augmentation if safe. Check for malpositions or CPD. Plan for a cesarean section if arrest persists. So this is how you can manage the manage the situation if the patient is 70 centimeter dilated and has not changed for 4 hours with good contractions. So that is the basic intro about what is an abnormal labor. Moving on to the etiology of abnormal labor. So the etiology, you should be knowing about the 4Ps, that is the power, passenger, passage, and psych. So always organize causes by the 4P mnemonic because it tells you where to act. First one is power. So power, the uterine contractility may be weak, that is uterine inertia we'll say, or uncoordinated, that is hypotonus. So power is uterine contractility may be weak. So think oxytocin misuse, exhaustion, or electrolyte imbalance. So that is the power. Second is the passenger. Check for the fetal size, presentation, that is matter, macrosomia, malpresentation, which can be like for example breech presentation, face presentation, all malposition, that is persistent occiput posterior, or any fetal anomalies can slow descent. So that is the one of the etiology of the abnormal labor, that is the passenger. Third is the passage. So check for the passage, check for the maternal pelvis and soft tissue, contracted pelvis, pelvic tumors, or previous carrying which causes mechanical obstruction, that is the CPD. So these are the things which can affect the passage, which can lead to an abnormal labor. Next is the other cause. One more P is which I have mentioned, psych. Psych is the severe, like psychological, severe anxiety, inadequate support or analgesia can impair the maternal bearing down efforts in the second stage. So clinically, the your assessment should be based on the 4Ps, or that is a you should target which P is dominant. So you have to check which P is the major cause of the abnormal labor for in that situation. That will tells you the next step. which can be augment contractions, correct the presentation, or proceed to the operative delivery. So that is the importance of these 4 P's. And other causes like you can see multiple pregnancies, if there is a uterine anomalies, these are the also the causes of any abnormal labor. So like for example, uh, imagine a combination which is like usually common. You can see, for example, large baby with inadequate contractions. If in this case you need a combined plan, so you should so here what you are seeing, large baby, so the passengers size, inadequate contraction, that is about the contractions. So this is the, so in these cases you need a combined plan. So this is how, so you should, it is very important to know the etiology of abnormal labor, what causes the abnormal labor, and what and how you can correct it. So if you know these four: power, passenger, passage, and psych, then it is very easy for you to decide for the next procedures. That is what called the etiology of abnormal labor. Moving on to the classifications. So classifications, you can see it's very important to know the clinical patterns. So first one is prolonged latent phase. So here long pre-active labor with slow onset, usually conservative management and analgesia, and admit the patient if exhaustion or dehydration. That is how we can do in the prolonged latent phase. Next is the prolonged active phase or protracted. In this case, there will be slow cervical dilatation in active labor. First line measures include the reassessing the contractions, amniotomy if membranes intact, and oxytocin augmentation if indicated. So WHO recommends confirming delay before augmentation and cautions against high starting oxytocin regimens. Third is the secondary arrest of dilatation or active phase arrest. So here no cervical change despite the adequate contractions or after defined time intervals. Manage as per the local protocol, often surgical decision if no response to the augmentation. Contemporary guidance which will want to the individualized decisions and avoid any premature cesarean in borderline cases. So that you can do in the secondary arrest of the dilatation. Fourth is a prolonged second stage. So prolonged pushing, risk of maternal exhaustion and fetal distress can be seen here, and consider the instrumental delivery if criteria is met. And so this is how you can do it, is based on the individualization. Next is the obstructed labor. So obstructed labor is due to the mechanical failure of descent despite the strong contractions. This is an emergency case, so think about the CPD and transverse lie or impacted shoulder, like shoulder dystocia and all, you can see. So that because of that you can check for the obstructed labor. Last is the precipitate labor. So precipitate labor is very kind of like a rapid labor. Watch for the perineal trauma and postpartum hemorrhage. So this is how the what is the precipitate labor. So these are the different types of abnormal labor, and so always document the pattern on your partograph or labor care chart, so it will guide the escalations. So most of the time, like I have one question to you: which pattern is most commonly leads to a cesarean for a labor dystocia? Which pattern is most commonly leads to a cesarean section for labor dystocia? That is the active phase arrest or secondary arrest or obstructed labor. So this is the most of the pattern. In these patterns, active phase arrest or secondary arrest or obstructed labor, in this pattern which can lead to a cesarean for the labor, abnormal labors will do a cesarean. So that is the classification of abnormal labor. So moving on to the clinical features. So clinical features of abnormal labor, you can see if the patient is having abnormal labor, clinically you will notice slow or absent cervical change on serial exams, fewer effective contractions, increased maternal pain and exhaustion, ketonuria or dehydration, and on fetal side, abnormal CTG patterns, late decelerations or reduced variability can be seen. On inspection of the head, you may see marked molding or cap cut indicating prolonged pressure. If the head fails to descend despite good contractions, suspect the obstruction. And look for Band's ring, BANDL apostrophe S, Band's ring, or abnormal condor of the abdomen in extreme obstructed labor. So these findings should trigger timely escalation. So we should be knowing the clinical features of abnormal labor. And so that is the important point here. And there is one more red flag in present. Like if the patient's having, like if there is a maternal tachycardia with fever with uterine tenderness, in this case you should suspect infection. So in these cases you should manage it urgently. So that you have to note the point about the red flag. Now, moving on to the investigations and monitoring, how you can investigate. So, here investigations are most of the time will be bedside. You should ask about the detailed labor history, continuous serial partograph, or the and you have to monitor the progress and detect the deviation early. Partograph will be very useful to reduce the delayed recognition of dystocia. So, you should be able to know the partograph monitoring, and use pelvic examination to assess the dilation, station, and position, but minimize the unnecessary exams if membranes are ruptured. Ultrasound is very useful to confirm presentation, fetal lie, and estimate the size or liquor if doubt exists. And fetal heart monitoring, that is intermittent auscultation or CTG, must be used to detect any distress. And if the CTG is abnormal, then escalate and use lab reports like investigation like CBC, cross match if bleeding, or operative delivery anticipated. Think the blood group, HP, coagulation if PPH, postpartum hemorrhage risk, is suspected. So that is the important point in the investigations. And like this is very important, especially the partograph monitoring is very important in case of abnormal labor. So investigations should be done properly in cases of abnormal labors. Moving on to the management in OPD management, how you can do the management in IPD, like abnormal labor. In OPD, like antenatal care, most of the time antenatal care, our job is like to prevention planning. So management in the OPD, like you can also always counsel the patient regarding the risk factors whenever the patient comes for the antenatal visits. So regular antenatal checkup and early identification of the risk is very important. So risk identification, during the antenatal checkups you can identify the risk, like you can identify macrosomia, diabetes, GDM, malpresentation if it is breech or any other presentation, pelvic risk, like you can ask for a history of CPD or pelvic injury and all. Counseling and birth plan. So discuss the possibility of operative delivery in high risk cases. Large because large baby, in cases of large baby or prior uterine surgery or placenta problems, you can always counsel the patient and regarding the birth plan also. And next is the optimize the maternal health. So treat the anemia, correct the malnutrition, and manage glucose. And good antenatal counseling reduces the anxiety and improves the maternal cooperation in the labor. So always remember the 4 P's: the psych, that is the severe anxiety about the labor to the in the mother. So you should be always it should be always very helpful to give a good antenatal counseling during the antenatal care checkup. Next is the external cephalic version, that is the ECV, for term breech if indicated, done in antenatal care under the ultrasound and after counseling. Next is you can use the referral plan. So for high risk mothers, schedule delivery in a facility with operative delivery and the blood bank. So these are the friend loaded work you should do to reduce any emergency conditions and in the case of obstructed labor. And if you always do this management in the OPD priorly, then you can reduce the emergency, and it will always improves the outcomes. So while the antenatal care checkup only, you should be always counsel the patient regarding the possibility of that labor. Moving on to the management of IPD. So IPD, it should be like a stepwise approach to active labor. So first one is to assess the patient, assess, confirm the progress on partograph, examine the cervix, station and fetal status, check the maternal vitals, hydration, electrolytes. So you should be able to assess the patient. Next is the, if slow progress with inadequate contractions, that is a power problem, because that is because of the power problem. Consider artificial rupture of membranes, amniotomy. If membranes intact and head low, and consider oxytocin augmentation when confirmed delay exists. So WHO recommends oxytocin with amniotomy for confirmed delay, but cautions against the augmenting before confirming true delay, and against very high initial doses. So always follow your institution's oxytocin protocol and monitor the CTG closely. Third is, if malposition, if it is due to the passenger malposition, try maternal repositioning. Epidural modification may help. Consider operative vaginal delivery if head is low and criteria is met. Fourth is, if arrest despite adequate contraction, discuss with the senior. If no response to augmentation and no reversible causes, proceed to cesarean section for arrest of labor. So that is the one thing you can do in the IPD level. So practical safeguards, you can say, continuous fetal monitoring during augmentation is important. Strict fluid balance and oxygen support as needed. If oxytocin is used, stop infusion for hyperstimulation or hyperstimulation or abnormal CTG, and call the senior immediately. So that is a practical safeguard you can do in the IPD. So next, moving on to the complications of abnormal labor. So what are the complications of abnormal labor? There are three: uh, maternal and fetal and long term. So maternal, you can see exhaustion, infection, uterine rupture, PPH, higher cesarean rate and surgical morbidity. Fetal, you can see distress, hypoxia or asphyxia, birth trauma like brachial plexus, clavicle fracture and all, you can see. So NICU admission is required. Long term, increased risk of repeat cesarean pelvic floor issues. Early recognition and the right escalation path will reduce these harms. So that is the important thing in under the abnormal labor, and these are the complications you might experience in the abnormal labor. Moving on to the summary of the today's session. So final take homes. First one is, use the 4P approach: power, passage, passenger and psych, to quickly identify the dominant cause of the dystocia, that is abnormal labor. Use the partograph or WHO labor care guide to detect the deviations for early and avoid the delays. Third is, for inadequate power, consider amniotomy with then oxytocin augmentation with continuous fetal monitoring. Fourth, for obstruction or arrest that does not respond to correction, tiny cesarean is safer than prolonged indecision. Fifth is, practice shoulder dystocia drills and ensure operative delivery competence in your unit. So early multidisciplinary action saves the babies as well as the mother. So that is the important things you have to keep in mind, and always our aim is to save the safe outcome for give a safe outcome for both mother and baby. So that's all for today. Thank you so much for patient listening, and have a great day.